This is going to be the summit ring for the experts debate, uh, and it's going to be refereed by evidence. So there are lots of debate about suction these days. This is the hot topic of endourology with decreased pressure due to the suction devices that we have currently available. And I would like to challenge both Mariano and Kymora for what is the best suction device for kidney stone management. In order to understand that, it might be a good option for both of you to basically describe what is this, what is FANS, and afterwards we can follow up with your presentations. Okay, please. So, Kymora, you'll be the first to begin.
Okay, so while we wait for, there we go. Okay, so this is a battle, okay? But before we start the battle, I want to just explain to everybody, what are we fighting about, right? So it's the battle of suction devices. And as I mentioned in my last talk, when we treat stones, and one of the things that has come out in recent years is the ability to use suction to help to clear the stones. So I'm going to start first with our patient, all right, Senora Lopez. Um, and she's 52. She has a 1.5 centimeter lower pole stone. She has a history of ureteroscopy already. She doesn't really want to have ureteroscopy again. She had a stent and she didn't like it. And, she really doesn't want to do mini PCNL either. So, what are the options for her? Okay. So for a 1.5 centimeter stone, if you consider ureteroscopy, it's an outpatient procedure. It's minimally invasive, but typically the stone-free rate is low. Residual fragments exist in about up to 58% of cases with a stone that's greater than 10 millimeters. And so, despite the fact that she doesn't want to do a mini PCNL, if you offer her ureteroscopy, there's some problems there. So ah, this is where suction might come in. And as I mentioned, residual fragments happen with these cases. You have the true stone-free rate is less than 50%, and we've all seen this. We've all treated this patient and seen, a stone on ultrasound when they come back to see us in clinic. If you're unable to move the stone to the upper pole, you often cannot clear that stone. You cannot basket the fragments, and dusting might still leave stones there, right? If you try to syringe aspirate, you may still have stones. So here comes suction. So what suction is with ureteroscopy is a way to, when you use the laser to break up the stone into small pieces, either by fragmenting or dusting, have a suction that is connected now in some way so that you can pull those pieces out. So you're not now just relying on a basket to take the pieces away. You're not just relying on the patient clearing the stone particles themselves, because a lot of times when you dust, those stone particles will just, fall into the kidney and they stay there. So there are two different ways of suctioning that we're going to be discussing. But what suction can help us with is it avoids PCNL, right? While also keeping pressures low, because that's another thing we're worried about with ureteroscopy, the increase for infection as you increase pressure. It effectively clears the stone dust and the fragments, and it can decrease the number of procedures. So I mentioned if you would traditionally do a ureteroscopy, when you come back and there's 58% of residual stones, you have to have another procedure. With suction, there may be the opportunity to just have one surgery. And so there are two different types of suctions. These are the flexible ureteral access sheaths, or suction within the scope, okay, which is direct in scope suction. All right, Mariano will be talking a little bit more about. Okay, so again, like I said, the direct in-scope suction, flexible and navigable suction ureteral access sheaths, also known as fans. And I'm just going to say briefly, there is a third device called CVAC, which is a vacuum-assisted clearance. It's kind of like a ureteroscope. It also has suction. We're not going to discuss it here. It's only available in the US, and it's a very large scope. Okay, so let's talk about fans and why I think fans make sense. So we are already all familiar with ureteral access sheaths. We know how to use them, right? The difference with these sheaths is that the tip of the sheath is flexible as compared to most sheaths, which are firm. And because it's flexible, it can now turn, you can now deflect into your lower pole, your upper pole, whatever pole. Um, that means you have more maneuverability, which increases your efficiency. You have an improved stone free rate because now you can suction while you're treating your stone. And then you have decreased complications, less fever, less retreatment. What are the products that are available? So you have several products on the market and several coming down in the next few months. So you've got the Hoover from Dornier. The most popular, I think, is the Clear Petra from Welllead, which in the US is distributed by Carl Storz. You have the Elephant 2 by Yigao, and then you have a Innovex device as well. Okay. But what is fantastic about fans is it gives you options. Okay, so can we start my video? Wonderful. So you can see here that you can treat the stone, okay? But you can also, suction these pieces down. So this is looking like an access sheath, but instead of you just kind of bringing it down yourself, the suction will bring the stones down for you. And then you have different sizes. You've got 10 Frenches, 11 Frenches, and then multiple lengths. So you can, really look at what's going on in terms of your patient's length of their ureter, and you can decide what makes sense for you in terms of an access sheath. You use suction and then a pressure bag over suction. With this, you have a very small scope. You're going in. Typically, most disc scopes have a single channel. So think about that. If you have one channel, you've got your laser fiber going in there, and you're also suctioning through that same area. It doesn't work. You have to laser and then suction. Even in the new Poussin scope, for instance, where there is a dual channel where you can laser and suction at the same time, you have a lot of clogging. It's very small. You cannot fragment. You have to dust because the working channel is the same size as the regular working channel. And you can really only suction dust. Fans allow suctioning of dust and stones. So here I showed you this video, but look at this other one. So you're dusting away and all of that is coming down your access sheath. So it makes for a very efficient procedure. Okay. And there are randomized controlled trials that favor fans. Okay. So there are multiple trials coming down the pike, but some have already been done. So there are retrospective trials and a couple of prospectives. When you compare this to fans, there's a shorter OR time with fans, better stone free rate with fans, and better complete stone free rate with fans. And then on benchtop testing, similar things, right? So fans cleared all stone sizes tested up to 2,000 microns, so 2 millimeters, as compared to this. Again, with this, you can only dust. So fans is easy to use. It's quick setup. You know how to use an access sheath. It's safe, and you can have simultaneous lasering and suction. It's also cheaper. So, the Poussin scope costs about $1,000 USD as compared to fans, which can range anywhere from $275 to $500. And we already have access sheaths, so it's not that big of a deal to convince the people who make the decisions that we can try a different type of access sheath. And again, not everybody has disposable scopes, and not every hospital system is able to afford disposable scopes. You can use the fans with your old, faithful, reusable scope. You can use it with a disposable scope if you have one. You can use it with anything you have. It's a superior suction device. As I said earlier, it clears stone better, dust and fragments. It's easier to operate. There's almost no clogging. The steps are very simple, and it's cheaper. Okay, thank you.
Thank you, Kymora. And now we will hear Mariano. What is this?
Thank you
This
very
means
much. Thank you very much for
function.
giving me to defend this part of the section. Thank you, Kymora, because you performed the program. So thank you very much. Of course, that Kymora is the winner. Yes, you are the winner, of course. Yeah. Thank you very much. But well, I'll try to defend this and this is direct in scope section. Yes. And we know that the most important thing that we perform during a surgery of stone is remove all the stone. Yes, it's very, very important to do that. And for that, we need to choose, yes, the correct treatment for the stone that we have, yes, at the patient. Not only the stone, is the patient also that we need to change, and we need to choose or to what is the treatment that we want. When we start with flexible, we use a lot of basket, yes, and today we have different treatment with devices with suction, and probably this suction changed the paradigm of the treatment of stones, yes, for sure. And of course, if we have a big tube, obviously that we can remove more stone, yes. But in this case, we have different devices with suction. Yes, fans is flexible and navigated urethral access sheath. This is my time. Now is direct in scope suction. Sure, it's steerable urethral scope renal evacuation. And in mini perc, we have suction also, yes. But the problem is not always we can put and introduce an access sheath in the urethra, yes. This picture is one of the most popular and most famous in the world. Yes, and you can see that sometimes when we can introduce an access sheath in the urethra, we will have this kind of injury of the urethra. So if we have a big urethra, we can use a big sheath. But the problem is sometimes we have a very, very thin urethra, and that's a problem, yes? So, and in other things, when we have a damage of the urethra, we will have this structure of the urethra. So, in this case, we know that we have 7.7 to 18% of the procedure that we will have a failure of the urethral access sheath insertion. So, in this case, we need what? A WG stent. In this case, when we have a patient with a WG stent, we know that the patient, in more than 40% of this patient, will have dysuria, another pollakiuria, another urgency, and pain. So, have you ever have a WG stent here? Raise your hand. Nobody? No? Well, some patients, when had a WG stent, come to the consult and say, please, doctor, you can do all that you want, but please don't put to me a WG stent again. Yeah? And it's the real life. Yeah? Okay? So for this kind of patient, I think that it's important to remove the stone with one treatment. And in this case, we can use the DIS. When we compare, we can see in this paper from Somani to compare the BCNL with this, they showed that there are no differences in stone-free rate, and in stone that is not, there were no more big, but with a density in 800 unit Houndfield unit. So I think that is you can use this for this kind of stones with good results. So today we have the DIS we have Kymora show us the different flexible scope that we have, 7.5 with a 3.5 French channel, and the other is with a huge channel of 5.2 French, and you can remove different size of dust. We know that we have different advantages with this, yes, is the small caliber, low pressure during the procedure, and the vision that we have during the procedure is better than when without aspiration of the dust that we produce. But of course that we have some advantages. One of that is we can stack the dust in the channel that we are working. So it's very important to control the pressure that we are using during the procedure. So today we have a lot of different lasers to produce dust, yes? And we know that we name dust a stone or a fragment less than 250 microns, yes? But in this case, we can perform dust to 500 micras if we use the channel of 5.2 in the Pusen that is higher than the other device. So we have today's different devices to control the pressure inside the via. Yes, we have this kind of device that we can introduce the suction and the irrigation in the same channel, and it's control the pressure that we are using or we have during the procedure of the treatment. And it's very important to control the pressure that we have during the procedure. But the other thing, the other device that we have is Sure. Sure is a little bit higher or a little bit big in the diameter. Yes, we have the Tzevat. Tzevat is a flexible scope with at 11.9 French in the sharp. Yes, but the channel that it has is 7 French. So with this device, we can remove more stone and more fragment at higher fragment than when we use a common flexible scope. We have with this Sure, the removed stone increase a lot, yes? And we can see in this paper that for 100% stone-free, in this patient, in this case, they have 33% of the patient with stone-free, totally stone-free. And I think that is very important. The problem with this device is the size, because it's too much for all the urethra that we have in our patient. So in conclusion, the aspiration is the changing for the treatment of stones and in urology, increase the stone-free rate, increase the vision during the procedure. I think that is very important to continue with the control of pressure that we produce during the surgery, but it's very important to not force and be gentleman when we try to treat a patient with the access sheet and also with the device that we are using during the procedure. Thank you very much.
Thank you, Mariano. And now I would like to invite both on the stage. And could you please go to the stage?
Okay, so
And I would like both of you to defend with one sentence your presentation.
okay.
Okay, Kymora, what would be the most important thing that you would argue fans is better than this?
So I think the argument for fans is that it can really clear more stones. There are retrospective and prospective studies showing that this is fantastic, but it has to be dust. Now, if you have a 3 centimeter stone that you're trying to clear, that's a lot of dust. Fans is able to clear dust and fragments, and it does so efficiently.
And Mariano, what would your cause be about this? In which cases would you suggest to use these procedures?
Yes, I think that I usually prefer to use fans like this. Yes, because I think that it's very difficult to find the very dust. Yes, because we are speaking about dust and say yes, it's very important to find dust during the procedure and create dust, but it's very difficult to do. Also, if you have a hard stone, yes, I think that is very difficult to do. We use more fans than this because for us it's better to remove stones. For us is the cost of this is higher than fans also, yes. And I prefer to use a common flexible scope with fans and no this for this kind of patient. Of course, if we have a small urethra, yes, I think that it's important to have one this to use during this procedure.
Exactly. I would like to thank you all. I think you are both winners, and the thing that would be important is the pressure, probably.
Yeah.
Both devices decrease pressures and the complications post-operatively. So there are new kind of technologies that will be with us, and maybe they will improve. Thank you so much.
Thank you.
Okay, so so round 2 And so now for round two, Mariano comes back again, but now you two are competing. Okay, and so the question is for round two, does medical management of kidney stones require targeted treatment? And so we'll start with Mariano, and he says yes. No.
We will have the slides with the no. Um, this topic is a little bit not so interesting as the fans and this in the endourology community, but it's a general measures that we can have. So does medical management of kidney stones require targeted treatment? I will try to defend this. They do not require a targeted treatment, and empirical therapy is enough, actually. So my conflicts of interest with would be endorobotics AI, but nothing to do with this talk. Uh, uh, Kymora's told us about the guidelines. The EAU, the European guidelines, are keeping updated themselves every year, but since many years they have this statement as a fact. They haven't changed this statement since many years. So there's an inverse relationship between high fluid intake and stone formation, and increasing water intake reduces the risk of stone recurrence. If we drink enough fluids, preferably water, and we allow for 24-hour urine greater than 2.5 liters, this means that we are going to decrease the risk of stone formation and decrease the risk of stone recurrence. So this is a general measure and it's an empiric treatment. The medical management of kidney stones, the AA guidelines. I don't know if there is any new for the medical management recently. Yeah, it will be probably this month. There are reviewers in February this month, and they will be released after 12 years. But still, the general measures are important. They evaluate the diet therapy and pharmacological therapy. I would like you to emphasize that there is about 10% prevalence in all the world about the kidney stone disease. And in 10 years' time, they recur about 50%. And if we just do empirical treatment, like diet and fluid intake, we will be able to reduce about 60% of the stone recurrence. The medical and dietary history is important for the screening evaluation, like assessing for obesity, diabetes, gout disease, which is related with kidney stones, and intake of some kind of medication like topiramate, vitamin C, calcium supplements is important for the screening evaluation. We do some chemistry tests like electrolytes, sodium, potassium chloride, bicarbonate, and calcium, renal function tests like creatinine, uric acid tests, and also parathyroid hormone, which is related with the kidney stones. Also, we need to have urine analysis to measure the pH levels, to see the crystals that are in the urine, and to see any kind of infection in the urine. In cases that we can do a stone analysis, we would like to do that and to see the composition, which would direct the specific therapy, but only 30% of the time. Oops, sorry. So for the candidates who need 24-hour urine testing would be the recurrent stone formers, children of any age, like patients with solitary kidney or intestinal disease like coronary bypass surgery, Crohn's disease, malabsorption, or gastrointestinal bypass surgery, gout, type 2 diabetes, renal tubular acidosis, or the patients who are interested and are first-time stone formers. We usually analyze for volume of 24-hour volume, pH, calcium, oxalate, uric acid, citrate, sodium, potassium, and creatinine. So the general measures would be to have a urine output of 2.5 liters a day. This is an empiric treatment. The other empiric treatment would be to have a normal calcium diet. If we restrict the calcium, this is a risk for high stone formation due to calcium binds the oxalate in the gut and prevents it from reaching the kidney. So normal calcium diet. And we also like as a general measure to limit the sodium intake. In case we have a high sodium intake, high salt intake, this would mean the high sodium would go as a urinary calcium excretion in the kidneys and will produce kidney stones. Even though for some specific type of stones like uric acid and calcium stones, decreasing the animal protein on the diet definitely decreases the uric acid and acid load, which lowers the urine pH. And even with the genetically diseases like cystine stones, aggressive fluid intake as an empiric treatment, as a general measure, is so much important. So we have a high risk stone formers. If this is 100%, not every patient refers to the specialist. This is a lower percent, and only 7.4% they complete the 24-hour urine testing. And we have to take into account that if we test, does the outcome change actually? No, it doesn't change. We need to know if our tools work best. There is a nice study of She at 2020 which compared empiric therapy with a selective therapy, and the results were similar. Also, with the precision dosing, they did not yield any kind of difference with thiazide dosing. Placebo, the same. You can see even 50 milligrams of thiazide diuretics had the similar outcome for stone recurrence. So we should be a little bit smart in the medical management of kidney stones. When we target 80%, it's identical and we don't need a map to find it. So the universal protocol would be hydration and normal diet, and sometimes the medication that Mariano is going to tell us a bit. We don't need to do costly testings, specialist time, patient logistics. We can do it with diet actually to have a similar outcomes. We would like to treat the patient actually, and we don't need to treat urine. But of course, for the 5% of the population in the pediatric patients with cystine or struvite stones or renal insufficiency or solitary kidneys or refractory cases that fail the empiric therapy, which is only 5%, we should go with the empiric testing. I would like to thank you for your attention, and I would like to invite you once more to join us in Istanbul in 2029. My weapon to convince you would be Ingrid at this time of my second talk, because she is in the organizing committee of 2029, as she was with the organizing team last year at Phoenix, and she did great things to convince the board to have it in Istanbul last year. Thank you all. Thank you, Ingrid.
Mariano makes the case for yes.
Yes, of course. Of course. In this case, yes, for sure. Now, as Tzevat said, not all the patients are the same. Yes, we have more than 80% of our patients with calcium stones, but we have a small amount of patients without calcium. Yes, and in this case, we need to treat. Yes, we need to treat and change not only the quality of life of the patient with difference, with more water, less meat, also with treatment for this patient. But we have patients with high risk, and we must recognize this kind of patient to study, because it's totally different. We have a patient with low risk to form stones, and we have a patient with high risk. If we have a patient high risk, it's very important to perform a metabolic study to do the specific treatment for this kind of disease that the patient have. Of course, if the patient have a lot of events of stones, if the patient have event when he is when the patient is very, very, very early, it's very important to perform a metabolic study, yes? And we know that we have part of the salts that can produce more stones, and we have inhibitors of stones, yes, magnesium and citrato, and it's very important to recognize that in the metabolic study. But we have another promote of stones, and it's very important to recognize that to treat correctly the patient that we have with a lot of patients, yes? And we know that we have pro and cons in the treatment of different patients, and when we have a high risk of patient for the stone formers, it's very important to say to the patient that increase the intake of water, yes, more than 2 to 2.5 liters a day, and decrease, obviously, the amount of meat that the patient had during the day, yes, because, of course, this protein increase the risk of stones formers, yeah. The other thing is salt, yes, the sodium, yes. Tzevat said that is very, very important to reduce the amount of salt a day, because this is one of the more important things to reduce the forms or the creates a new stone during the day. But it's very important also the intake of calcium. Yes, it's very important to decrease the salt, but maintain the intake of calcium during the day to decrease the probability to create a new stone during the treatment. And also the oxalate. Yes, the oxalate is one of the other things that can increase the amount of stone procedures, yes, and it's very important to know that. But one of the different things or the different stone that we have is struvita. And when we have a stone, an infection stone, the struvita, it's very important to remove the stone, but then when we remove all the stone, and it's very important to remove all the stone, because if we have a stone, a rest of stone, a part of stone in the kidney, this stone has infection indeed. So it's very important to remove all the stone during the treatment, but it's very important after this. Yes, if we not have a stone, not have bacteria, it's very important to treat with antibiotics and with ácido acetohidroxinámico to reduce the amount of infection that the patient will have during the next 6 months after the treatment. Yes, and it's very important to know that for this kind of patient, we have to control the patient at 6 months with an ultrasound or a CT scan to recognize if the patient created a new stone or not, yeah? But we have another kind of patient, yeah, the patient with a bypass, with a gastric bypass, and in this kind of patient, we will have a stone with an hypohydraturia and hyperoxaluria, yes, and it's totally different the treatment that we will have in this patient. It's very important to increase the liquid, but increase the citrato, yes, citrato potassium, and reduce the oxalate and increase the calcium, because the calcium chelate the oxalate and remove this calcium with oxalate with the fecal material. But we have another kind of stone, is cystinuria. The cystinuria, we know that is aminoaciduria, yes, and the cause is the bad absorption of in the terminal part of the proximal renal tube, yes, and in this kind of stone, it's very, very important to increase the amount of water, but also decrease sodium and decrease protein. It's very important to do that. Why that? Because we know that the protein and sodium increase the possibility to move with this, the cystine, to the urine, and increase the possibility to form a new stone of cystine in the kidney. And for this kind of patient, we have different medicine, yes. The depericinamina the problem is the toxicity that has, and the thiopronin, I don't know if you use thiola, no? Well, the thiola is not so toxic as the penicillamine and is a chelant of the citrate and decrease the possibility to form a new stone in the mm, first part of the treatment after they remove the stone. So if we have a patient with a first case of stone, it's very important to increase the amount of water, reduce sodium, and reduce protein of meat. Yes, meat protein. But if we have after that, post-treatment, another event of the stone, is very important to remove all the stone of the patient, has a negative culture of this patient, a control with metabolic study of this patient to increase the treatment of it with the correct treatment for each patient that we have. Of course, that if the patient has the first event of stone, it is very important to do that Tzevat said. Yes, a lot of water, they reduce meat, reduce salt. But if the patient has a high risk of a stone former, yes, it's very important to study this patient to do the correct treatment for the patient that we are home. To take home message, is very important to identify what is the high risk patient and low high patient to form stones. Recommendate the treatment for the general treatment for all these patients that we have with stones. But if we have a infection stone, remove the stone and the correct antibiotic for this patient. If we have no acid, no stone, no bacteria, no stone, but it's very important to derive for us, it's very important the nephrologist to treat this kind of patient. Yes, we have a lot of patients with stone, and it's very important that the nephrologist perform the correct treatment for the patient that we will have. Thank you very much.
So now we have the rebuttal, Tzevat and Mariano, both going back. So Tzevat, what would you say is the most important thing to think about when you are doing medical management for the patients?
Um, well, actually, compliance is my mainly concern with the patients. So, in case we have kidney stones, everybody knows that they are going to recur and they are going to come to the hospital in 5 or 10 years with a kidney stone episode. But if this period is really long, 5 years time, nobody is taking care of that idea. And it's a little bit different from the hypertension that you have to use the medications, you have to control your pressure. So I find that uh, making the patient to perceive this entity of kidney stone, that there is going to be some kind of medical management, dietary or with drugs, is the most important thing. So it's a bit of paradigm shifts in the mind of the patient, that the patient has to be followed up for all the life. That would be my first thing that has to be considered, to convince the patient about the compliance of the follow-up.
Okay. And Mariano, with targeted therapy, what is the most important thing when you are following your patients?
Yeah, that's the problem. The problem is that the patient needs to recognize the importance to do the treatment, the correct treatment. And that's the big issue that we have with the treatment of this kind of patient, yes. Because at the end, when the patient has the pain or has the event, yes, said, yes, we will have all, we will take all the pills that you said. But at the end, when the patient pass the days, the patient decrease the amount of pills that have, and it's very difficult to have a patient that continue with the treatment for all the long life. Yeah.
Okay, thank you, gentlemen. So, the next section, we're going to be talking about sort of complex stone treatment. And so, our next speaker is going to be Dr. Marcelo Batusi, and he's going to talk about innovations in endourology.